Ya, huruf P kayak ada hanya Hasya.
Tiga, untuk menjadi institusi kelas dunia yang menawarkan standar internasional pendidikan mengikuti pesatnya perkembangan teknologi kedokteran gigi dan kebersihan mulut. Sebagai kampus terbesar di Indonesia Timur, kami selalu berusaha untuk memberikan yang terbaik. Desain kurikulum yang terdepan dan menarik, tenaga pengajar profesional, proses belajar mengajar yang nyaman, fasilitas terbaik, kegiatan ekstrakurikuler yang menyenangkan, program beasiswa untuk para mahasiswa, dan sebagainya. Kami berharap mahasiswa dapat menikmati studi mereka dan menyelesaikan pendidikannya dengan cepat dan hasil yang baik. Hingga kini kami memiliki 11 profesor, 26 doktor, 24 master, dan 17 spesialis. Semuanya siap membimbing siswa kami untuk menjadi dokter gigi yang handal. Kami pun memberikan program spesialisasi bagi mereka yang ingin mengembangkan ilmu kedokteran gigi. Untuk meningkatkan kualitas dan wawasan, Fakultas Kedokteran Gigi Universitas Hasanuddin sering mengadakan kuliah tamu baik dari dalam dan luar negeri, beberapa kerjasama internasional dengan Belanda, Jepang, dan Taiwan.
Fakultas Kedokteran Gigi Universitas Hasanuddin memiliki visi untuk menjadi pusat unggulan dalam pengembangan insani, ilmu pengetahuan, teknologi, seni, dan budaya yang unggul dalam kedokteran gigi dengan berbasis semangat benua maritim Indonesia. Di samping itu, kami berusaha untuk meningkatkan mutu pembelajaran dengan metode student-centered learning berbasis kompetensi dan menyediakan lingkungan belajar berkualitas untuk menunjang pembelajaran yang inovatif dan proaktif. Untuk mewujudkan visi tersebut, kami menetapkan misi untuk mempersiapkan dokter gigi masa depan yang memiliki kemampuan untuk menerapkan dan menyebarluaskan ilmu pengetahuan dan teknologi kedokteran gigi berdasarkan etika dan moral. Dan kami pun tanggap terhadap perubahan dan perkembangan iptek kedokteran gigi secara global.
Sesuai dengan tujuan pendidikan dokter gigi di Indonesia, yakni sebagai pendidikan profesi yang mendidik mahasiswa sesuai dengan kurikulum dokter gigi yang bermoral Pancasila serta mempunyai sikap pengetahuan dan keterampilan, Fakultas Kedokteran Gigi Universitas Hasanuddin menerapkan dan mengembangkan sistem pembelajaran yang efektif, efisien, dan tepat waktu dengan berbasis kompetensi, serta meningkatkan budaya meneliti yang berkualitas dan berkesinambungan bagi dosen dan mahasiswa berlandaskan etika dan moral. Meningkatkan aktivitas dosen dan mahasiswa dalam forum akademik nasional dan internasional. Mengembangkan potensi sivitas akademika melalui kegiatan pembinaan kerohanian, bakat, minat, kepemimpinan, etika dan kepedulian sosial, dan kegiatan pengabdian masyarakat berlandaskan semangat maritim.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good morning, ladies and gentlemen. I saw that Dr. Aziz already, Dr. Sodi already here with us, as well as Dr. Anita Agustin, and Dr. Ganesha. Good morning, Doc.
Good morning.
Yeah, we're still waiting our Vice Rector to join with us before we begin our webinar for this morning. I hope you don't mind. He will soon be here with us. Yeah, our Vice Rector already here with us. I'm Ernie, Dr. Sodi. I'm the one who traveling you with my WhatsApp via Dr. Ganesha for this meeting. I do apologize if we causing you inconvenience. Let me say hi to our Vice Rector, Prof. Nasrum. Assalamualaikum, Prof. Nasrum.
Ya, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Selamat pagi, good morning, Prof.
Morning. Yeah.
Good morning, Prof. I hope you are well and healthy.
Yeah, thank you.
Okay, so ladies and gentlemen, we have everyone important for this meeting. So I will let our Master of Ceremony, Dr. Christine, we have Dr. Ruslin as well, to guide us all along this event. Dr. Ruslin, monitor. Yeah. Everybody, I leave this event to Dr. Christine. Please, Dr. Christine.
Thank you, Dr. Ernie. The Honorable Rector of Hasanuddin University, Professor Dr. Tuya Aristina Pulubuhu, MA, who is represented by Vice Rector, Professor Dr. Muhammad Nasrum Masih, PhD, SPMK, the Honorable Dean of Faculty of Dentistry, Hasanuddin University, Dr. Gigi Muhammad Ruslin, MKes, PhD, spesialis bedah mulut konsultan.
Saya bilang jangan terlalu dengar yang begituan, biarkan saja.
The Honorable, our speaker today, Dr. Aziz Sohdi. Ladies and gentlemen, distinguished participants, good morning and best regards to all of us. Assalamualaikum warahmatullahi wabarakatuh. We would like to warmly welcome you all today on the 10th Virtual International Symposium Series that held by Faculty of Dentistry, Hasanuddin University, today in theme, Innovation in Aesthetic Composite System, a Restorative Update. Ladies and gentlemen, as the beginning of this webinar, we would like to invite Vice Rector of Hasanuddin University to deliver a welcome speech to Professor Dr. Muhammad Nasrum Masih, PhD, SPMK. Please, Prof, the time is yours.
Thank you very much, Christine. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Dean of Faculty of Dentistry, Dr. Ruslin, my brother, and the Honorable all speakers in the Virtual International Symposium Series 10, with the theme Innovation in Aesthetic Composite System, Restorative Update. Thank you very much for this invited us to give a speech as a representative for rector. I'm very sorry because of rector had another activity, so she asked me to give a speech in this event. As a vice rector for research, innovation, and partnerships, I think this is a very good activity, and we from Hasanuddin University always support this kind of activity because of this is one of the branding university to audience, I think. And another thing is to increase the knowledge and skills of our staff related with the specific topic, especially in dentistry. Another thing is if there is a possibility for UNHAS, if there is a foreign scientific who want to have a collaboration in the publication or making together a proposal to get a grant, research or publication together, as I said, and research collaboration. We really support this kind of thing, and because of UNHAS now try to reach the world university ranking, and as information for all of you that UNHAS now in already in the list of world university ranking. This year we enter in the 1001 until 1200 in the world, especially for the KS ranking. But for the time higher education ranking impact factor, we are in the 79 ranking in the world. In Indonesia, we are in the second level. That's why all of research activity and the same like in here for the international symposium, we hope that many things that we can get outcome related with this activity. Hopefully that many staff related with the dentistry will join in this symposium and can get more benefit related with the topic for the today. Actually, there is so many symposium series already running by dentistry, Faculty of Dentistry, Hasanuddin University, and now in the 10 times already. So hopefully that this is still continue for another topic related with the topic with the dentistry. I think that is the all I have to say in this conference. Then very thanks to all the organizing committee to arrange this symposium, and hopefully that all of us get healthy because of pandemic. We still have productive to do some scientific meeting like this. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much, Professor, for the kind welcome speech. Now, ladies and gentlemen, we are enter the main part of this virtual international symposium series with our international speaker from Singapore, who will talk about innovation in aesthetic composite system, a restorative update. And this session will be led by Chairman Dr. Gigi Nur Hikmah, Specialist Konservasi Gigi Konsultan. A brief introduction of the Chairman, born in Ujung Pandang, September 1983, graduate her dentist degree from Hasanuddin University and conservative dentistry specialist from Hasanuddin University, and achieving a consultant degree in Surabaya at 2019. She is currently a lecturer staff of Conservative Dentistry Department in Faculty of Dentistry, Hasanuddin University. To the chairman, Dr. Gigi Nur Hikmah, please, Doc, the time is yours.
Thank you very much. Thank you very much, Dr. Christine. Ladies and gentlemen, before we start the presentation, and in order to avoid any disturbance during the presentations later, I would like to ask you to change the mode of your gadget into silent. Let's do it together. Thank you. And let's start. The Honorable Rector of Hasanuddin University, Professor Dr. Duya Aristina Pulubuho, MA, the Honorable Vice Rector of Hasanuddin University, Professor Dr. Muhammad Nasrun, MA, PhD, and the Honorable Dean of Faculty of Dentistry, Hasanuddin University, Dr. Gigi Muhammad Ruslin, MKes, SPBM Consultant, PhD. The Honorable Madam Speaker, distinguished guests, fellow students, ladies and gentlemen, good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, first of all, I would like to welcome you all to this prestigious seminar about anterior and posterior composite, conventional and adhesive cementation that held by Virtual International Symposium Series 10, Faculty of Dentistry Hasanuddin, collaboration with PT Gratia Jaya Mulia. Okay, in this occasion, we shall have outstanding presentation from our prominent presenter, whom I believe shall enrich our insight and knowledge regarding to the theme of this seminar. Before we begin the seminar, allow me to introduce the presenter. Our presenter is Dr. Aziz Sodi. Our presenter today is Dr. Aziz Sodi. She is the product manager at Kafo Care and support the APAC region in management of core restorative and endodontic solution product portfolio. She has over 8 years of experience in healthcare management and dental industry. And Dr. Aziz has a professional degree in dentistry and is postgraduate in healthcare management. Okay, I introduce you Dr. Aziz, and without further ado, I would like to welcome our presenter, and she will deliver a presentation entitled Innovation in Aesthetic Composite System, a Restorative Update. Okay, ladies and gentlemen, please welcome Dr. Aziz Sodi, and her time is about 1 hour. Dr. Aziz, the floor is yours. Dr. Aziz.
Hello, good morning. Thank you so much for the introduction. I'm really excited to be here with all of you to share some of the latest innovations that we have. I will begin to share my screen now.
Okay, I'm sorry, Dr. Aziz, your video.
Yes, you should be able to see.
Yes, I'm sorry, Dr. Sodi, your video, please. Your video still offline.
Are you able to see now?
Yes.
Okay.
Please, Doc.
All right, so okay, so thank you for the introduction, first of all, and really excited to be here with all of you. The topic that we have, as we've just shared, is innovations in aesthetic composite systems. So a brief introduction about myself. I am the product manager for Kerr Restoratives and Endodontics in APAC region. And our company, Kevo Kerr, has been into manufacturing dental products for over 100 years. So that means that our products have a legacy, have a clinical history of being in the market and serving dental clinicians such as yourselves for a long period of time already. In today's session, the objective of our session and the course outline is to share with you the latest innovations that we have under the restorative portfolio. And these are some of the products that we have selected for this discussion that will help you to simplify your workflow and also deliver high clinical outcomes. So without any further ado, I am going to get into the session and the content that I want to share with you. Okay, so looking at this picture here, what are we seeing? We're seeing beautiful smiles, and that's also something that is trending in the market these days. So you would have noticed patients walking into clinics and asking for a beautiful smile or improvement in their smile. We don't see patients really asking for amalgam or gold restorations anymore. So tooth colored restorations are what people are looking for, and that's also in line with the kind of trend that is there in the market, which is more aesthetic driven. So how can we offer such a beautiful, natural looking smile to our patients? So really the very first step of any restorative workflow is adhesion, right? And I'm going to share with you some basics of adhesion, the various surfaces that are involved in adhesion, the product that we can use in order to achieve high bond strengths, and then follow it up with composite materials that can be used to complete your workflow and give a beautiful smile to our patients, right? So talking about adhesion first. So there is a lot of study in the market. There's literature review that tells us that if you're talking about adhesion, it is one of the most difficult and the most researched science in overall restorative dentistry. And so why do most clinicians think that it is also a difficult part of the workflow to master? That's because of the various surfaces that are involved in adhesion. So when we're talking about adhesion, we're talking about enamel surface, we're talking about dentine surface. So let's talk a little bit about the enamel surface first. So we know enamel by weight and composition, it is highly mineralized, right? So it's very hard. It's about 96% mineral. That makes it a highly mineralized substance, one of the hardest in the body. So when we're trying to etch or bond to the enamel surface, what are we really doing? We are going through a process known as enamel etching. You would have heard it in second year, third year dentistry. What it does is during this process, you're using an acid that helps to dissolve the mineral or the crystals that are there on the surface. And as a part of the process, you end up removing around 10 microns of crystals from the surface, which results in surface roughening. So that means that your surface becomes rough. And because of this roughening, the resin that you apply onto the roughened surface will flow into the microporosities that you have created and result in a micromechanical bond, which is formed with enamel, right? So let's look at the images here. These are SEM images. When you look at these images, you can see the image on the top is really a pattern that is more aggressive. It's very visible to you. You can see it's much more aggressive than the pattern that you see at the bottom of the image. So why do we have a more aggressive pattern? That's actually an end result of using a strong acid. So as a part of enamel etching, when you're using a strong acid, that is the kind of etching that you get and the pattern that is formed on the surface. So there are microspaces that are formed. Following this process, when you apply the bonding agent is able to lock itself in place, and a high percentage of minerals in enamel is removed as a part of the enamel etching, which you can see in the first image. Now, when you look at the second image, there is still a pattern that you see, but it isn't as aggressive. And this has been formed as a part of a self-etch process. So you've used a self-etch bonding agent. Self-etch bonding agents typically have lower acidity, and they still remove minerals from the surface, but the pattern that is formed is not as aggressive. And we will learn about the differences between self-etch and total etch in the following slides. But keep in mind these two images and the etch patterns that you see, and the difference between total etch as well as self-etch when it comes to etch patterns. Okay, so the second surface that we're talking about here is dentine. Dentine in nature is pretty different from enamel. It is less mineralized, about 70% mineralized. There are other structures in the dentine. There is collagen, there is water, there are dentinal tubules. It is 20% organic, 70% mineral. So it makes it a softer substance as compared to enamel, which is much more mineralized as compared to dentine. And there are various factors that complicate the dentine bond and that have to be taken into consideration when you're trying to bond to the dentine surface. So we have dentinal tubule morphology. There is sclerotic dentine that is formed as the patient grows older. And then there is a smear layer which is also formed onto the surface, which has to be taken into account if you want a strong dentine bond. So what is a smear layer? A smear layer is actually a byproduct of your cavity preparation. And what does that mean? It is formed as a byproduct of your cavity. So when you're preparing the cavity using a handpiece and a burr, as a part of the process, there will be crystals, there will be inorganic substances, organic substances, water and bacteria, all of this mixed together that form a layer on the tooth surface. This layer is actually called the smear layer. And it very tightly adheres to the tooth surface. It's not something that will be easily washed away. And that is why we need to take this into account when we are bonding to the dentine surface, because it can interfere in the dentine bond that you're trying to form. So you either need to remove the smear layer or you need to modify the smear layer in order to have a strong dentine bond. So we saw how micromechanical bonding looks like on the enamel surface. Let's look at how micromechanical bonding looks like in the dentine surface. So if you see the image here, it's pretty different from what we were looking at in the enamel section. So what we are doing here is that you're using phosphoric acid as a part of the total etch process. When you use phosphoric acid, there is intertubular dentine that is demineralized. Okay, as a part of the demineralization, the intertubular dentine is removed, and so there are spaces formed. However, the collagen fibers that are there inside the dentine, they still remain in place. There are microspaces that are formed, and when you apply the bonding agent or the adhesive on top of the surface of the etched dentine surface, this bonding agent then penetrates into these microspaces and locks in place. So that is the micromechanical mechanism that is taking place on the dentine surface. Okay, so we talked about enamel, basic composition of enamel, basic composition of dentine, and how micromechanical bonding occurs on both these surfaces. Now let's also take an understanding of what are the different techniques that are available in the market. So there are two basic techniques that you will hear about, read about, and also practice. The etch and rinse technique, which is also called the total etch technique, and then the self-etch technique. Now, what is the total etch technique? Or etch and rinse technique. So what happens in this is that you're using a separate etching step. And in order to conduct this step, you're using a separate phosphoric acid, right? So the etch and rinse means that you're etching as a separate step, and then you rinse, dry the surface, and follow it up with your bonding agent. Depending on the number of bonding agent bottles that you're using, you can either be using a 4th generation or a 5th generation. 5th generation is one bottle system where the primer and the adhesive are in one. And then the 4th generation bonding agents are where you have the primer and adhesive in separate bottles. So that means that if you're a 4th generation doctor or you chose a 4th generation bonding agent, you're actually doing 3 steps: etch and rinse, followed by priming, and then adhesion. So 3 steps in total. If you're a 5th generation bonding agent, or you've used a 5th generation bonding agent for your technique, what you're doing is basically two steps. There is a etch rinse step, and then you're using a single bottle system to do your priming and adhesion. Now, this is different from self-etch. Self-etch, as the name suggests, the etching is actually a part of your bonding protocol. It is a part of your bonding system. So that means that you don't need to do a separate etching step using a separate phosphoric acid. The etch is already inside the priming. Right, so you could either be doing a two-step technique wherein you're using two bottles. So there is a primer which is also acting as an etchant, and then you have your adhesion. Or you're using a 7th or 8th generation bonding agent where the primer and the adhesion are part of the same bottle. Okay. Now let's look at how they look when we are talking about the bottles involved. So in a 4th generation bonding agent, as I explained, there is an etching step, there is a priming, and an adhesion step. So there are 3 different steps. The difference between 4th and 5th generation is the fact that the priming and the adhesion are put together into one. So the doctor is actually doing 2 steps. There is an etchant, and then there is a combined priming and adhesion step. Now, 5th generation or 4th generation bonding agents fall into the total etch category, and total etch bonding agents have been associated with very high enamel bond strengths. And just a quick thought, why is total etch bonding agent associated with high enamel bond strength? And that's because we are using a separate etchant to etch the surface, a separate acid to etch the enamel surface, which gives us a very aggressive enamel etch pattern and gives us high enamel bond strengths. A very popular bonding agent in this category is our OptiBond S. It's a very popular bonding agent. It's been in the market for about 30 years. It is a 1-bottle system. You're using priming and adhesion together in one step. And you're able to deliver high bond strengths on enamel as well as dentine. So look out for this bonding agent. It's also available in Indonesia. Okay, so let's look at what is happening on the enamel and the dentine surface when we're using total etch bonding agents. So you can see the top image here. The image on the top is actually enamel, where we have used a separate phosphoric acid step that gives you high enamel bond strengths. And then if you look at the dentine surface, it's different from how enamel looks. Dentine, you can see these spaces. These are micro spaces that have been formed as a part of the etching process. In total etch bonding agents, dentine bonding is invariably associated with higher incidence of post-op sensitivity. So there is much more chance of our patients having a post-op sensitivity with total etch bonding agents because of the fact that it is a more technique-sensitive procedure. And that is the reason, one of the key reasons why dentistry came up with, or manufacturers came up with, self-etch bonding agents. That was to reduce the incidence of post-op sensitivity from total etch bonding agents. So let's get a better view of why are total etch bonding agents associated with higher incidence of post-op sensitivity. Okay, so just look at this image here. Imagine this to be the tooth surface that has been etched with phosphoric acid. So what happens is that when you etch the tooth surface with phosphoric acid, there is intertubular dentine that is dissolved, and you can see these spaces that are formed. However, the collagen fibers, which are just like your hair, still remain. So as a part of the process, if the doctor happens to rinse and dry, in the dry step, if they're applying a lot of pressure onto the tooth surface, what happens is that there is a chance that the collagen fibers will collapse. And if the collagen fibers collapse, what happens is that when you apply the adhesive on top of this tooth surface, there will be spaces that remain that the bonding agent is not able to penetrate and seal. And because of these micro spaces, there can be post-op sensitivity that the patient experiences. And that is one of the key reasons of higher incidence of post-op sensitivity, because of the bonding agent not being able to seal these micro gaps that are formed as a part of the process. So if you're looking at an SEM image, how does a moist dentine look like? So you can look at this image here. The moist dentine should look like something like this. However, the dry dentine you can see is very glossy, shiny here in the image. So what is actually a visual indication of a moist dentine? So if you're looking into the patient's cavity and the cavity looks glossy, doesn't look dry, then you know that your surface is not over dried. However, if your cavity is dark, it's dry, there's no gloss, then probably the indication is that you have applied a lot of pressure while drying it out, and you have probably dried out the dentine. And the collagen fibers have collapsed as a result of that. So that is a clinical tip to keep in mind when you're doing a cavity preparation, to observe the surface of your cavity after you do your drying step. So another clinical tip, when you're talking about etching, how long should you be etching your enamel? So general recommendations is that you should etch your enamel for at least 15 seconds. Also, because of the fact that enamel is highly mineralized, there are very little chances that you would over etch it. But when it comes to dentine, you have to take into account the over etching possibility. And question that can come to your mind is that, can you over etch dentine? Think about it. So the answer to this is yes, you may over etch, you are able to over etch dentine, and that is why it's important to take into account certain guidelines. So as per this study, there are general guidelines for adolescent, adult, and sclerotic dentine that we may follow, which is for adolescent dentine about 5 seconds, adult dentine you could take about 10 seconds, and then sclerotic dentine, which is more mineralized, harder to etch, you could take into account around 15 seconds of etching. Okay, so we talked about etch and rinse, total etch bonding agents, and the fact that total etch bonding agents can be associated with higher incidence of post-op sensitivity. So in order to address that, another procedure or another technique was introduced, which is known as the self-etch technique. The self-etch technique is where, as the name suggests, the etchant is already inside the bonding system. So you could either use a 6th generation, which is 2 steps, or a 7th or 8th generation, which is a 1-step technique. So when it comes to bottles, what are you really doing? You're using an etch, priming, and adhesion step. So as a part of the 6th generation, the etchant here that you see as a separate step is already included in the primer. So that means the doctor is essentially doing 2 steps. You have an etch and priming in 1 step, and then you follow it up with adhesion. So self-etch, because the priming bottle already includes the etching function, and so it is able to etch the surface on its own. Now let's look at the SEM images of etched enamel and etched dentine using this technique. So if you look at the etched enamel and try and recall the etched enamel image that you saw from the total etch section, you will realize that the etching pattern here is not as aggressive. It is a smoother pattern. This generally has a lower enamel bond strength as compared to total etch bonding agents. And we discussed the reason why. Now, if you look at enamel dentine, the etched dentine here, what we do on the dentine surface is that we modify the smear layer using our self-etch bonding agent, and this delivers a good dentine bond strength, however, reduces the post-op sensitivity, reduces the chances of post-op sensitivity, very low post-op sensitivity probability or possibility using the self-etch bonding agents. So again, why is that? Let's try and understand the mechanism of self-etch bonding agents. So what happens is that you imagine this as your dentine surface. So as a part of the self-etch protocol, the doctor is going to apply their primer here onto the surface. The primer has the etching action, will also dissolve um, the minerals, intertubular minerals, and create spaces. Now, these monomers, which are there inside your primer bottle, are responsible for etching, but also responsible for bonding, and so they are not washed away. So we have no rinse and wash away step in a self-etching protocol. So these monomers are able to penetrate and they stay there. They are not washed away. And so there are no spaces that are formed which need to be filled by a subsequent application of the material. So because there are no spaces that are formed in here, there are much lower chances of post-op sensitivity when it comes to self-etch technique. Okay, so no micro gaps that are formed, no nano gaps that are formed. Okay, so some clinical tips of using 6th and 7th generation bonding agents. Instrument and etch enamel wherever it is possible. So in case you're looking at a cavity that has a lot of enamel that you see is involved in the cavity and you need the bond strength to come from enamel, then instrument the enamel, make sure that you're etching enamel with a phosphoric acid step, selectively etching that, and then etching the dentine surface with your self-etch bonding agent. So this technique is actually a selective etch technique where you're selectively etching the enamel surface. However, the dentine is being etched using the self-etch bonding agent. All right, so moving on to the latest entry into the bonding agent portfolio as well as bonding techniques is the universal bonding technique. Now, what is universal bonding technique? We talked about total, we talked about self-etch bonding agents, and now there is also universal bonding agents that is available. Now, if we have to define universal bonding agents, universal bonding agents are those materials that are able to bond to all different types of materials that are there. For example, they're compatible with gold, they're compatible with rexilium, they're compatible with zirconia or porcelain fused to metal PFM materials, composites, all of these materials. Universal bonding agent should be is something that you can use in different procedures. That means that if it is a direct workflow or it is an indirect workflow, you're able to use it in either of these procedures. So you don't need to have a separate bonding agent for a direct protocol and a separate for indirect. The third item or characteristic of this bonding agent is that it can be used in different indications. So whether it is a total etch indication or it is a self-etch or the doctor chooses to do a selective etch technique, they can use this single bond to do your 3 different indications. So the real benefit here is that a universal bonding agent is able to help you reduce your inventory. So you don't have to have different types of bonding agents for these different clinical requirements. And yet you don't need to compromise on your clinical outcome or the bond strength. And we will see how. Okay. So when we talk about universal bonding agents, what is the role of universal bonding agents? So when we look at adhesion workflow, you're actually talking about the tooth surface and you're talking about a composite material. So the role of a bonding agent is to act as a connector between your bonding agent as well as your composite material. Now, bonding your tooth surface and your composite material, these are 2 oppositely natured substances. Right, your tooth substance, your tooth surface is actually a water-loving surface. It is hydrophilic. It loves water. On the other hand, your composite material is hydrophobic. It doesn't like water. It repels water. So imagine a drop of oil in a glass of water. The drop of oil is not going to mix with the water, right? So it's a different natured substance. So the role of a bonding agent is really to connect these oppositely natured substances together. How is the bonding agent able to do that? So the characteristics required are, firstly, for the tooth surface, the bonding agent should be able to penetrate the tooth, right? So it has to have low pH so that it applies or provides a good etch and gives us a strong mechanical bond. It should be able to chemically bond to the surface. So you have a micromechanical bonding and you have a chemical bonding. It should also have low viscosity, so it's able to penetrate the etching, the surface that you have etched. And then it should be hydrophilic, right? Because for a good contact between the bonding agent as well as your tooth surface, you need the material to be at a very low contact angle. So it should be adequately hydrophilic as well. When we're talking about the restorative surface, what is it that you need at the restorative surface? You need the material to have enough functional groups, methacrylate functional groups, so that it is able to bond. And it should also be able to form a strong bond so that there are no gaps, or there are, you minimize the micro gaps that are formed. So you need a strong bond that is formed with the composite, and you need the material to bond well with the tooth surface as well. And as I explained, these are oppositely natured substances. So when we talk about these oppositely natured substances and the fact that the bonding agent should be able to contact and bond with both these surfaces, the chemistry of your bond becomes very important. And that's actually the star element of our bonding agents. We use a monomer called GPDM monomer. We have a patent on this monomer. It is the monomer that only our company can manufacture. No other company in the market is able to use this monomer, as we hold a patent on it. It's called the glycerophosphate dimethacrylate monomer. As you can see on the screen, it is a bipolar monomer, meaning that it has two poles. There is one pole which anchors to the tooth surface. It is the phosphate group. It helps to form an ionic bond with the enamel. And then you have two methacrylate groups here. You can see here. These two methacrylate groups help to form a cross-linking covalent bond with the composite material, right? So it forms a very strong bond with the composite material. So that's about our monomer. The other key component of our bonding agent is the solvent. So any bonding agent, for your information, will have two key components, the monomer as well as the solvent system. The solvent system that we use, again, we have a patent on this technology. Most other manufacturers or products that are there in the market use either one solvent or a combination of two. We are able to use three solvents in one. And what is the advantage? We're using water, acetone, and ethanol. So we call it the ternary solvent system, as it is a 3-in-1 solvent. So what is the advantage to you, to doctors, when they're using a ternary solvent system? So what happens is that when we have acetone in the system, in the bonding system, so acetone is a very volatile substance. Acetone will rapidly evaporate from the surface, and that increases the concentration of your monomer on the surface. All right, so imagine a glass of water in which you've added a teaspoon of salt. Now, when water evaporates from the glass, the water that is left behind will taste more salty. And that's because the concentration of the salt has increased in half a glass of water. The same concept applies here. The acetone, which is a part of the solvent system, it is volatile, it evaporates, and that increases the concentration of the bond on the tooth surface and helps to give a strong etch pattern on enamel. So you get a strong enamel bond strength. Now, the ternary solvent system also helps us on the dentine surface. We have ethanol as well as water, and both of these help in the hydrophilic nature of enamel. They help to re-wet the collagen fibers and make sure that they don't collapse, and therefore allow a deep raisin tag formation. Now, deep raisin tag formation is helpful because it gives us a deep and strong hybrid layer formation, which results in a higher dentine bond strength. So really with a ternary solvent system, we are able to achieve best of both worlds. You're getting high enamel bond strengths and you're getting high dentine bond strengths as well. Okay, so that was about our universal bonding agent, which is called OptiBond Universal. If I have to give you like a summary of the different types of bonding agents that we have based on the technique, you have OptiBond FL, which is a total edge bonding agent. And as you can see in the image here, it is a two-step, two-bottle system. OptiBond S is again a total edge bonding agent. It is a one-bottle system. Okay, and then we have self-etch OptiBond Extra Universal, which is two-bottle system as well, and OptiBond Universal, which is a single bottle system that you can use in all different indications. It is a universal bond, and we just discussed it in detail. So it really helps you to simplify your workflow, and you can use it in multiple etch indications as well. So when you're using OptiBond Universal or the universal bond, how do you apply it? What is the technique that you need to follow when you're using it in a total etch or self etch or a selective etch technique? Now let's see total etch and selective etch. So if you're a total etch doctor, you will first etch the surface, rinse and dry. If you're using a self etch technique, you will only selectively etch the enamel surfaces. So in a selective etch technique, only select the enamel and apply the phosphoric acid on the enamel, rinse and dry. Follow it up with the bond. So you will shake the bottle, dispense it in mixing well, close your bottle, and then apply this bond onto the tooth surface. So it's very important to note that when you're applying the bond onto the tooth surface, it has to be in a scrubbing motion. You need to agitate the surface for about 20 seconds. So this contact time is important because we want to scrub the tooth surface. This also helps in evaporating the acetone and helps in a stronger bond. So you do that for 20 seconds, air thin for 5, and light cure for 10. So very simple protocol, 25, 5. So that is your protocol for direct restorations. Now, when it comes to crowns or indirect restorations, again, you're following the same protocol. You will scrub, you will rinse, you will dry, and you will light cure. Moving on to veneers, for example. Now you want to use OptiBond Universal in cementation of a veneer. So veneers usually involve a lot of enamel, and so we will recommend using a total etch technique. So you will apply phosphoric acid, rinse, dry, apply the bond. Again, the same protocol. Use a scrubbing motion for 20 seconds, air thin, and light cure. And then finally, complete your cementation protocol. All right, so that was the technique for using OptiBond Universal in total etch, in selective etch, as well as in indirect etch as well. Now I want to share with you a video. In this video, we talk about the different components that we just shared with you, which is the GPDM monomer as well as the solvent, and the key functions of both of these components and how they help you in the etching protocol. So I will play the video now.
Dr. Sodi.
Dr. Sodi, excuse me. Dr. Sodi. Dr. Sodi, excuse me. Your video sound, please. Dr. Sodi, are you monitor? Your video sound, please.
Yes, can you hear me?
Yes, but your video sound is off.
Hello. Can you hear me?
Yes, doctor, but your video sound is off.
The video sound is off.
Yes.
Do you hear it now?
I hear your voice, but your video is off.
You can go to share screen option, Doc. I think there will be an option to share your audio.
Yes, I have actually shared my audio.
Okay.
Just
Okay.
Yes.
hear it now?
Yes.
Okay, so I will play it again.
Thank you.
Okay, so
that was the summary of our OptiBond universal and the technique that we use, the chemistry that is there in OptiBond universal. So we talked about the adhesion protocol, the different techniques that are there, surfaces involved, and the latest innovation in the space of adhesion. The next segment here is on composites. Before we talk about the latest innovation, I just want to take you through what are the different characteristics that we are looking at when we select a composite material, and then a bit of a history on composites as well. So when you're selecting a composite material as a dentist, what are you really looking for? So if you just think about it, for most of the materials that we use in our day-to-day dentistry, we touch and feel all of those materials. So it's a very tactile science. And that is why the handling characteristics of your material are very important. You don't want a material which doesn't feel good in your hands, which is either too hard for your practice, or it is too soft or too sticky. So it makes it difficult to complete a restoration in time. So handling characteristics, physical characteristics are important. The other component is radio opacity. We also want materials to have low shrinkage, so there is low stress that is created, less chances of micro gaps. You want a material that has good polishing characteristics. So that means that you should be able to polish your restoration quickly. You also want that the polish of the restoration lasts for a longer period of time. So polishability as well as polish longevity is important. And of course, at the end, all of these characteristics come from the fillers or the science of the material. So that is also important. I'll just talk a little bit more about radio opacity, because many times this is one factor that isn't really talked about a lot or can be ignored. Radio opacity is something which makes the material more opaque or visible in your radiographs. So you want the material to have high radio opacity. It should have like at least 100% aluminium. To be visible. You also want the material to be visible in radiographs so that in secondary visits, you're able to diagnose any kind of caries. You're able to differentiate your restoration from the rest of the tooth. So a high radio opacity is something that we must look for when we are looking at or selecting materials for our practice. All of Kerr's composites have at least 200 to 250 aluminium to be able to be easily differentiated in radiographs. So we take that into account in manufacturing our materials. Now, let's see how composite space or composite technology has evolved over a period of time. So originally, when composites came into being, were being manufactured, they were mostly macrofill materials. Macrofill meaning they had large filler particle size. So these materials, as the name suggests, were infused with big fillers, big size fillers, so macrofills, as the name suggests, and they had higher fracture toughness. They were also more stiff. These materials were less polishable because it was harder to polish and achieve a glossy surface with these substances, and they would also gather more stain or get stained more quickly over a period of time. So the aesthetic component was poor. So in order to address those gaps, there were microfill materials that were introduced. Microfill, as the name suggests, is filler technology, which has smaller filler particle size. So these filled materials are more polishable as compared to macrofills, but they had lower strength, lower fracture toughness. The latest materials that are there in the market are called nanofill materials. Now, nanofill materials are infused with nano-size filler particles. Now you can see nano-size is actually so much smaller than 1 micron. So it's really small filler particle size that has been used in nanofillers or nanofiller technology. Now, how do nanoscale filler particles help us? And how they're different from microfills, for example. So if you look at these two images and compare, imagine this surface to be a tooth restoration that has been filled with filler particles that are bigger in size. Now what happens is that when a patient with this restoration goes back home and they brush their teeth about 100 times, the surface on top of the tooth surface, it gets worn off. The resin that is there on the surface will get worn off as well, and the fillers will get exposed into the oral cavity. Now this effect is called the plucking out effect of the fillers. So what happens is that when these get plucked out, there will be craters that are formed. These craters, over a period of time, because of the roughening of the surface, will gather stains. The patient restoration will lose its longevity. It's going to lose its polish, and the patient can complain with staining or dull restoration or yellowness of their restoration as a part of this. Now, on the other hand, if we look at this image here, it is filled with filler particles which are much smaller in size. As the patient brushes their teeth, the resin that is there is still going to get exposed. It's still going to get worn off, and the fillers are going to get plucked out. But what happens is that because of the size of these filler particles, the craters that are left behind are much smaller in size. So that means that at a microscopic level, there is still the restoration is going to have its gloss. It's going to maintain its polish for a longer period of time, and there are less chances of the patient to complain of yellow restoration or staining of their restorations. So it's much easier to achieve a higher gloss, and it's much easier for the patient to maintain that gloss over a period of time. Okay, so the latest product that we have in this space is called Harmonize. Harmonize is a universal composite material. You can see this is the packaging of the material. It is available in syringes. It's also available in unidose packaging. And this material is something that you can use in your anterior part of the oral cavity. You can also use it in the posteriors, which means that you don't need to have separate materials for separate indications. So if you wanted to do a veneer, or you wanted to do a class 3 restoration or a class 2 restoration, you could use this material. Now, what is the science that we've used in this material? What is the filler technology, which is key for all the characteristics? We have used silica and zirconia particles. Silica by nature is negative in charge. It's negative charged. And then you have zirconia, which is positive in charge. So both of these are oppositely charged particles, and they fuse together and form spherical balls. These spherical balls are then infused into the resin matrix. So you can see this brown substance here is actually it's a pictorial representation of the resin matrix. So we infused these into the resin matrix in order to form the composite material. So the basic science is using silica and zirconia infused spherical filler particles into the resin matrix. And because of this combination of particles, we are able to mimic the behavior of natural tooth. Now, the next question you might have in your mind is, what is the behavior of natural tooth? Now, our natural enamel behaves differently in lower wavelengths of light and higher wavelengths of light. And so we want our restoration to mimic that behavior, so it looks similar to natural teeth in higher and lower wavelengths of light. So when it comes to blue light or low wavelengths of light, human enamel reflects more diffuse light, which means that it looks matty. It won't look very shiny. It won't shine. However, when it comes to higher wavelengths of light, for example, red light, your human enamel gives out more specular, or it shines light back at you. So it's going to be more glossy. So you want your composite material to also mimic this behavior of a natural enamel in low wavelengths as well as higher wavelengths of light. And with this combination of zirconia as well as silica that we use, we are able to mimic that behavior. And so our material is able to mimic the behavior of human enamel in low as well as higher wavelengths of light. Right? And we have, when it comes to shade offerings, we have 3 different shades ranges. We have dentine, which is the highest in opacity. We have enamel, which is the second or the lower in opacity, and then incisal, which is a non-Vita shade range, and it is the lowest in opacity. So we offer around 30 different types of shades that you can select from in order to complete your restoration. Okay, so let's look at some real-time images of real patients from our KOLs and clinicians from across the world. So this is a restoration that we've completed using B1 enamel only. So Caucasian teeth can be whiter than Asian teeth, and B1 enamel is therefore used. This is another case that we have done. It's been shared by Dr. Brian Harris, who's one of our key customers and clinicians in the US. And then you have this again, 8 and 9 being restored using A2 enamel and A2 dentine and A1 enamel. So we've used dentine as well as enamel shade to complete here. Okay. So when it comes to composite portfolio, I just shared with you our universal composite material, which is harmonized. And then we have bulk fill material, sonic fill 2, which is a different technique from universal composite materials. And it is a very innovative product. It can be used in posterior restorations, which are deeper restorations, which may take a lot of time when you're trying to do a layering technique. So a bulk fill material will allow you to fill the entire restoration in one shot for 5 mm of depth. Right? So I will share with you more details on sonic fill later towards the end of the presentation. Now, before we get into bulk fill restorations, let's do a quick summary and understanding of shading when it comes to universal composites as well as veneers. So you look at this graph here. This is the Munsell color system, and it is used to understand the different dimensions of color. So when we look at color, there are 3 basic attributes. There is hue, which is the basic nature of any color. There is chroma, which is the second attribute, which actually represents the degree of color or how much color there is in a substance. And then value, which is the third component, which you can see in the vertical bar here. Value is the brightness of the color. So white would be maximum value, black is 0 value. So if you look at this palette here, and you have to think about the hue of this palette, then that's going to be yellow. If you look at the chroma, then this part of the palette has higher chroma because it's more filled with color, and this part has lower chroma as it has lesser yellow. It has lesser hue in it. So that is the dimensions of color. When it comes to natural teeth, how do we derive the various dimensions of color in natural teeth? So hue, which is the primary source of color, in human dentition, it is dentine. Dentine is what gives you the vitality, the warmth of the tooth, the yellowness of your teeth, or the color of your tooth. Chroma, the second dimension in natural teeth, also is dictated primarily by the dentine, and it is influenced by the translucency of your enamel, right? So when you're looking at the cervical part of your tooth, that's where you would see maximum chroma. And then value, again, is influenced by the thickness and the quality of enamel. So if it's a younger enamel, there'll be higher value as compared to older patients. There is another dimension of color that you would see, which in human dentition, which is opalescence. And it is actually this blue comb-like halo structures that you see in the incisal region, which are due to the reflection of the hydroxyapatite crystals in the enamel structure. So another dimension to note when you're looking at your patient's teeth. Now, since enamel regulates the color of the teeth, we also see how thick the enamel is in different parts of your oral cavity, different parts of the tooth. So let's look at the cervical cross-section of the tooth. And in this cross-section, you can see in the cervical part, the enamel is really thin. It's in about 0.3 mm. So that is where you see maximum chroma. When you're selecting your dentine shade, you will look at this part of your tooth structure. Middle third is where there is increased light scattering. The thickness of enamel is greater. It's around 1 mm. And that is where you actually match your enamel shades when you're selecting your shades. And then the incisal part, where you see most of the characterization, such as opalescence or any kind of translucency or opacity that you see, is in here. When it comes to enamel, there are actually clinically, you would see 3 different types of enamel in general. There is a young enamel, which is more white in color. It's thick. It's less translucent. When it comes to adult, the color becomes more neutral. There is the translucency is intermediate. It is not as thick because there has wear that has occurred over a period of time. And then as you look at older patients, you will see that the enamel has become really thin and it is more wear that has occurred. So opalescent effects or incisal edges will not have much of opalescence because of the fact that there would have been a lot of functional wear that may have occurred in older patients. Okay, so let's talk about shade taking in composites. Now, since we have talked about shades, we've talked about the different components and attributes of colors. So clinical tip to take into mind when you're doing a shade taking procedure for patients is to make sure that you observe the tooth in natural light. You're looking at the cervical part for your dentine shade, the middle part for your enamel shade. Also beware of the dehydration effects. Make sure that you are doing your shade taking prior to isolation, because if you isolate the tooth, there will be dehydration that occurs and that changes the color of your tooth. So if you match it against this tooth, the restoration is not going to match with the rest of the tooth in the oral cavity when the patient rehydrates, right? So it's important to do your shade taking against the natural tooth in natural light prior to isolation. So another clinical tip here for shade taking is many seasoned clinicians would create their own customized composite tabs where you're actually curing the material to see the actual color that it's going to deliver versus using acrylic shade tabs, because then you're matching your shade against acrylic tabs, which may not be 100% accurate. So this is another way of making sure that you're referring to actually the cured composite material and how it looks after being cured. Okay, so that was about shade taking. Now let's also talk a little bit about veneers as well as the veneer preparation. So if we see here, there are basically majorly three different types of veneers. There can be a facial view, a partial veneer, a full veneer where we do a window design, and then a full veneer where we have the incisal edge involvement as well. So many times there can be questions on whether on which incisal design to take, whether an incisal lapping design or an incisal butt joint to take into account. So that really depends on the indication as well as the objective. So if you're looking to increase the length of the tooth, you may consider an incisal lapping design. If you think that the material that you're using for the veneer requires more strength at the incisal edge, then you may consider using the butt joint design, because that will give some additional thickness to your material. Okay, so let's move on to a very quick and easy to use direct veneer technique. In this technique, what we are doing is that we are going to be filling or creating a veneer, direct veneer for the incisor here. The point to note is that there is no inherent discoloration of the tooth here. So it only requires a tooth morphology change. So point to note. So first step, as we already discussed, we have to take into account the fact that we do the shade taking prior to isolation. You observe the cervical middle thirds for your dentine as well as enamel shades. Step number 1 here, in this technique, we are using two different shades, two different composite masses to complete the entire restoration. So a seasoned clinician may use 4 to 5 different shades as well to do a direct veneer. In this technique, we are using two different composite masses. So step number 1, we are using a tint. It is a color plus tint unfilled resin from Kerr. We are using the ochre shade, which is light brown in color. So make sure that we only apply a very, very fine film of that using a 0.1 brush. Okay, that is step number 1. Once you apply it, you will cure it. The next step here is to go to your composite. You select your enamel shade. We've taken a larger piece of enamel shade here and placed it on the composite material, on the tooth restoration, and used a favorite composite spatula to model the material. So it's important here. We've seen sometimes clinicians can take really small bits and pieces of composite material and keep adding it to the tooth surface. That is something that may increase your chances of incorporating voids. So it's important to avoid that technique so you're able to reduce the chances of incorporating voids. So a larger piece of material, when you take a larger chunk, it helps to minimize voids as well. So work this material, follow the morphology of the adjacent tooth. Work out the transitional line angles here using this flat composite spatula. And as you can see, we had a bit of an excess of material, so it's gone past the incisal edge. So we need to cut it off. So this is the cutback stage in which we cut the excess material against the level of the adjacent tooth. So many times clinicians can stop here. They can just cure and complete the restoration. However, this restoration will lack its incisal translucency. In order to add incisal translucency, we need to create space to add incisal shade, another opacity. So here we are using an IPCL, which you can see, please note the angle at which the IPCL has been held against the tooth. So it has to be at a slant. You don't need to create a butt joint. So create a slant, cut out the composite material, and then also involve the mesial and the distal surfaces. And once you've created that space, you can use a plugger or a conical instrument to create horizontal grooves in the surface to give it a mamelon effect. Following this, we will use the second tint. The second tint is actually light. You have to use a very fine quantity, very less quantity, so that you only see a glossy surface. You don't cause any pooling of the material. So use a 0.1 brush to dispense this material, this tint. It is a blue tint again from Color Plus, which we manufacture under Kerr, unfilled resin. And make sure that it doesn't pool inside the grooves. Once you have applied the material, you will then cure it and top it up with our second shade here, which is the incisal shade. Now we are adding this shade in order to give it a translucence that was there in the original tooth structure in the incisal part. Okay, so we are using again a composite spatula to tap the material down. This helps because if you don't tack it down, there is a chance that the entire mass begins to move. So it's important to tack it down and then work the rest of the mass. And there you, with final strokes, you can achieve the final restoration where you have used incisal shade as well as an enamel shade to complete the restoration. And finally, cure the material. Okay, so that was building up the tooth morphology. The next step is actually polishing, which is a key step, whether it is anterior or posterior. Now, before we talk about the polishing procedure, I want to share with you some conservative aesthetic procedures that you can use to give your restoration a narrowing effect or a widening effect, right? So that depends on the polishing again that we do. So if you feel that your tooth structure is a little too wide and you want to give it a narrowing effect, you can place the horizontal grooves closer towards each other, and that reduces the reflecting area. And that also gives the tooth a narrowing effect. Likewise, for widening, these can be placed further away from each other, and then that increases the reflective surface. Moving on, when it comes to shortening and lengthening, again, we can use some conservative aesthetic procedures to give the same effect. If you place these grooves, horizontal grooves, towards the incisal edge, that reduces the reflective area again. And because it reduces the reflective area, it also gives a shortening effect to your restoration. Okay, so let's look at these two images here. This is a fun question. Just look at these images and think in your heads which woman looks younger. So most of the times the answer that comes back is the one on the right hand side. But if we look closely, it's actually the same patient. And what we've done here is that we've just done some conservative cosmetic contouring of the teeth to give it a more youthful appearance. So we've just reshaped the incisal angles, and we opened up the incisal embrasures to give it a more youthful appearance. So these are certain cosmetic contouring procedures that you can keep in mind to improve the smile of your patients. Okay, so after we finish our direct veneer, the next step is to polish. And it's also important to observe your tooth surface from 3 different sides, angles, in order to make sure that you're properly contouring or polishing your tooth surface. So firstly, important to look at the incisal side. The incisal edge has to be flush against the tooth, which is on the adjacent side. So make sure that it's flush. If you see excess, then that is how you need to reduce. Also look at the transitional line angles. Here I have drawn it with pencil to show you that we need to build the transitional line angles and remove the excess, open up the embrasures accordingly. And thirdly, we look at the facial aspect from the lateral side. So you want to make sure that there is not excess of material at the cervical or the middle third, and you can use light brushing motions to reduce the tooth structure. The excess that is there. Finally, the last step is to round off your line angles and point angles. And that is important to do in the end, because if you do it in the start, you would still need to again round off the angle. So it's best to just do this step at the end. So that's the end of your primary anatomy. You can also look at the secondary anatomy, although in our Asian patients, we don't get to see a lot of secondary and tertiary anatomy, but just for your information, you can use a red band conical diamond burr to create horizontal as well as semicircular vertical grooves to give the secondary and tertiary anatomy to the tooth. Okay. A quick clinical tip here. Once we complete the restoration, we may sometimes find white spots in your restoration surface, and those white spots can be air bubbles that are trapped. So an easy way to fix it is use a round burr to create a saucer shaped preparation. And if you see that the cavity goes deeper into it, you can use a smaller number round burr to reach to the base of the cavity, and then etch and remove any kind of debris and use your bond onto the surface, add the composite, and then cure. Finally, use a disc shape polishing to smoothen out or uh, polish this part of your restoration to complete or repair the void in the composite. Of course, this also depends on the overall isolation that you have done and contamination of the tooth surface. So you have to take that into account. But this is a quick tip to repair a void in the composite. Okay, so with this, we have reached the final section of our today's discussion, where I will share with you a bulk fill composite material. So bulk fill is not something that we used in our traditional dentistry or studied in our traditional dentistry. We have always studied universal layering technique, where you place the composite material in about 1.5 to 2 mm thickness and cure each layer as you place it. So that's primarily because we want to reduce any kind of polymerization shrinkage or minimize polymerization shrinkage. Now, this also means that for deeper cavities, you need to spend a lot of time to build up the entire restoration. And therefore, in order to simplify and speed up the procedures, bulk fill materials were introduced. So the bulk fill material that we have from Kerr is called Sonic Fill. Sonic Fill is it's a very innovative system. It is one of its kind in the market. This material allows you to fill the restoration from the bottom all the way to the up in 5 mm of thickness in one shot. Also, you don't need a liner for this material. You don't need a capping layer. So it's truly one-step procedure. Now, some of the key questions that come into mind when we are talking about bulk fill materials are, what about the adaptation of the material in the bottom of the cavity? Now, if it's a deep cavity that has many lines, many line angles, many point angles, you want to make sure that the material adapts well to all these line angles and point angles. And we will see how Sonic Fill helps in doing that.
Pardon, Dr. Sodi?
Yes.
Pardon, your time's 5 minutes more.
Okay. All right, sure. The second key question that comes to the mind is the depth of the curing, right? So if we want to cure the material, we want to make sure that the material at the bottom and the top is equally cured. Third question that comes into mind is shrinkage. The material should have minimal shrinkage, and then of course it should have enough strength so it is able to withstand the occlusal forces. So because of the high filler loading that we have in Sonic Fill, the material can be used in posterior cavities. It has enough strength to withstand any kind of occlusal forces. Also the fact that it is a sonic energy activated system. Because of that, the material is able to adapt very well. So let's see a video and that will explain the adaptation part. So before that, I'll just take you through the components of the system. There is a handpiece that we use. This handpiece goes into the high speed of your chair. And then we have Unidos compules that have the composite material stored in it. So once you activate the handpiece, the material inside the Unidos is going to get activated, and it behaves like a flowable when it comes out of the tip. Okay, so that is the science that we use inside Sonic Fill. So let's look at this clinical video. So this is the Unidos that I showed you just now and the handpiece. So once you activate the handpiece, the material comes out like a flowable. And because it behaves like a flowable, it adapts very well to all the parts of the cavity. Okay, so here you can see material coming out as a flowable as it's been activated, and you can easily take it through all the parts of the cavity to fill the cavity. And since this is bulk fill, you're able to fill the entire restoration for 5 mm of thickness. So if your restoration is 7 mm of thickness, you would have to place 2 layers. And there you complete the restoration. This is the final video that I want to share with you, where you will be able to see very clearly how the material dispenses from the tip. One of the key tips here to ensure that your restoration does not get over filled or you do not incorporate any voids is to make sure that your tip is constantly dipped in the material. All right, so let's see. So as the material is activated, it comes out like a flowable, very easily flows through all the nooks and crannies. And you minimize any kind of voids because your material is constantly dipped through the entire procedure. So these are some of the tips that you keep in mind while you're using Sonic Fill, and it helps you to complete the entire restoration. All right, since we are very close to the end of this session, I will close with a video that I want to share with you that explains universal technique versus Sonic Fill, which is a bulk fill technique. Okay, so let's look at this video.
Okay, so
That is the final video that shows you the significance of using bulk fill in deeper cavities. So we are open for questions now.
Okay, Dr. Sodi. Are we open for question and answer now?
Yes, we are. Sorry, I'm just getting a glass of water. Okay.
Okay, very well, ladies and gentlemen. Now we come to question and answer session. And if you have any question, please mention your name and raise your hand. But before we go to the first question on Q&A answer, Doc, from Dr. Maria. How GPDM bonds to PFM or zirconia?
Yes. For GPDM, as I explained, the monomer is a glycerophosphate dimethacrylate. So there is a phosphate group that we have in GPDM, which is what bonds with your lithium ions in the zirconia crown. So it's actually a mechanism because of the fact that we've included the phosphate groups, which are part of the bipolar molecule that help in bonding to zirconia.
Okay, thank you. And the second question is from Dr. Ali Fadli. Excuse me, Doc. In your explanation, Optibond uses a ternary solvent system atau TSS. I'm sorry. There are water, ethanol, and acetone as solvent. Could you please explain about the mechanism of each and what are the advantages of TSS compared to other bonding agent that only use two solvent? Please, Doc.
I think we went through this in detail during the presentation. So we have TSS, which is ternary solvent. So acetone is a volatile substance. So as acetone evaporates from the surface, it increases the concentration and decreases the pH. Now, pH of your bond is very important. You want a low pH so that it etches your enamel surface, right? So that is the role of acetone. Being volatile, it helps in increasing the concentration of the bond and reducing the pH, which helps in a strong enamel bond strength. Now, the other component of your bonding system is actually your dentine surface. So as a bonding system, there are two main substances or surfaces that are involved. So there is a dentine and an enamel. So we talked about the role of acetone on enamel. The second part of the bonding is actually your dentine surface. So we studied in total H bonding agents. One of the key concerns that clinicians have is the higher incidence of post-op sensitivity. So because of the fact that we are using ethanol, which is actually it acts as a wetting agent. It rehydrates the collagen fibers. So it makes sure that your collagen is not, it doesn't collapse and it doesn't, just fall down, because of which when you apply the adhesive, there are still microspaces. So because of ethanol and water combination, which act as a wetting agent, the collagen fibers don't collapse, and this helps in deeper penetration into the resin tags that helps in formation of a deep hybrid layer. So the role of these two components helps in a stronger dentine bond formation. So with combination of water, acetone, and ethanol, we are actually able to achieve the best of both worlds, which is high bond strength on enamel, as well as high bond strength on dentine without having the chances of very high post-op sensitivity. So that's the advantage.
Thank you, Doc, for your explanation. And there is Dr. Dini Hamid. Please, Dr. Dini Hamid. Are you monitor?
Okay, thank you. Can you hear me?
Yes.
Okay, thank you, Dr. Sodi, for the presentation. It's a great presentation. First, I want to ask about the direct veneer, how long the direct veneer with curve harmonized will last, whether it's about the color properties and the strength properties.
Okay, so this is a question that we see when it comes to direct veneers. What is the life? That depends actually on a lot of different factors. It's not just composite material. It also depends on the oral habits of the patient, how much of coffee or tea they're drinking on a daily basis. What are their do they have bruxism? Do they have any kind of chewing habits that may affect the strength of the material? So it really depends on a lot of different factors. But we could say in average patients, maybe for a properly done veneer with the right bonding technique would stay about maybe 5 years, for example, as an average a number. But I wouldn't really put a number to the life of the restoration because it varies from patient to patient.
Okay. Can I ask for the second question?
Please.
Yes.
Okay. The second question about the sonic field. This is the bulk field system, right?
Yes, that's right. It's a bulk fill system.
Okay. So how about we use it in a deep cavity? How about the load stress distribution? Is it is it to crack will it is it to crack if we only use the bulk fill system than the incremental system?
So with sonic fill, because of the filler loading, so it has 80% plus filler loading in the composite material, which gives its mechanical properties. So meaning that the material is strong and can be used in posterior cavities as well. When it comes to various factors, for example, fracture toughness, compressive strength, etc., the life as well as the performance of bulk fill materials has been seen to be equivalent, if not better, than conventional restoration materials, but it comes with an added advantage of being able to be placed in one shot. If it is a 7 mm cavity or an 8 mm cavity, we would recommend 2 layers. But if it is 5 mm or lesser, we would recommend 1 layer, as it has been tested for that thickness of curing already. Yeah, so when it comes to the mechanical properties, because of the higher filler loading, the material is able to withstand the compressive as well as occlusal forces in the posterior cavity, and it is especially designed for posterior cavity as well.
Okay. The last question is it possible to achieve an aesthetic composite restoration with only 1 layer and single layer with one shade color?
So aesthetic restoration, this would depend on what your patient's expectations are. As I explained in the technique, if there is no inherent discoloration, sometimes doctors would also use maybe just 2 layers of harmonized, maybe a dentine and an enamel layer only, to complete their restoration, and not use multiple layers. So it really also depends on the expectation of the patient on how aesthetic they want their restoration to be. But when it comes to harmonize, because of the filler technology that we have used, the behavior of our restorative material is this material is able to mimic the behavior of human dentition very closely, because of the technology, that is silica and zirconia together. And we have seen our clinicians also being able to do aesthetic veneers, aesthetic restorations with a combination of maybe only 2 shades, and sometimes, depending on the clinical indication, even 1 shade. So it is a culmination of multiple factors of your how much is the discoloration, is there any discoloration or not, or what are the expectations of your patient. But if we have to only speak from the material standpoint, then because of the technology, the material has improved chameleon effects. It can mimic the behavior of natural enamel, and even 2 shades or 1 shade can be used to do a very aesthetic veneer.
Oh, okay. Thank you, doctor.
Okay, thank you, doctor. And we go to the other question from Dr. Angga Karim. Excuse me, doc. I have a question. What composite is best suitable for restorations that needs high aesthetic? Example, direct veneer based on filler particle size. Thank you, doc.
Yeah, so nano-filled materials, hybrid or nano-filled materials are the ones that use nano sized filler particles. So Harmonize uses the average filler particle size is really small. It is 50 microns. It is ideal for your direct veneers and aesthetic restorations because it has an improved chameleon effect. Yeah, so that is the material that you can use. And if it comes to range, we already talked about macrofills and microfills and the disadvantages because of the bigger size of the filler particles. Yeah, so nano sized filler particles actually helped in better light scattering, in better chameleon effect, improved chameleon effect. And the fact that we've used silica and zirconia together, the refractive index of this combination is also very close to what enamel has, and that helps in improved chameleon effect of the material as well.
Okay, thank you. That's so nanoparticle, yeah. And then we go to here. There is a Dr. Dila. Dr. Dila.
Yes,
Dr. Dila,
doctor.
please. Your time. You have any question?
Yes, of course, doc. So, excuse me, Dr. Asisodi.
Dr. Dila, please. Your video.
Wait, doc. Okay, done, doctor. Dr. Asisodi, I wanna ask doc about sometimes we got cases that old composite got chipped or small damage. Is there any tips how to bonding to old composite without replace the old composite and prevent further damage by using the bonding that you've promoted before? Is there any tips how to bonding to old composite without replace the old composite?
Yeah, so the material can be used to bond to composite materials also. So depending on how much of infection or how much of isolation your old composite material has, you may be able to use a bonding agent to add new composite material, and depending on the crack and how big is the damage, you may be able to add the composite material. You will follow the same technique that we have just discussed, in which there is an etching as well, self-etch component already involved. Rinse and dry to remove any kind of a contamination, and then follow it up with the bonding agent. And Optibond Universal is a one bottle system, so you wouldn't use a separate primer and adhesion. It is a one-step system.
Okay, about the selective etch, I think that you've mentioned before. Is that what about in unprepared dentin? Is it best to wrap with diamond or just etch like we used to do?
So you, if it is a selective etch technique, you would already have done a cavity preparation. So it is good to instrument the enamel. You do a cavity preparation already. And after the cavity preparation, if there is a lot of enamel that is involved, the bond strength is going to come from enamel. So you want to make sure that you etch the enamel using phosphoric acid, and then use the self-etch bonding agent, whether it is a 1 bottle or a 2 bottle system, on the dentine surface to complete the procedure.
Okay, thank you, doctor. Great explanation.
No
Thank
problem.
you, doctor. And we go to the other question from. I'm sorry. We have a question from Dr. Nurhayati Nasir. How do you arrange the shade of composite in order to make the tooth look shorter or longer? Please, doc. So the question is about how do you arrange the shade of composite in order to make the tooth look shorter or longer? Please, doc.
Yeah. So when we are looking at the shades, you have to select the shade based on the hue, chroma, and value that we talked about. So when it is a procedure which is not which does not which is an aesthetic conservative procedure, you can actually use polishing techniques to reduce the shade, the thickness, as well as the length of your material of your restoration, as well as the width of your material restoration. When it comes to shade taking itself, for the cervical part, you have to take a shade which matches against the cervical part of your tooth structure, which is the dentine shade. So dentine shade, when you're selecting your dentine shade, it has to be matched against the cervical part. That is a general rule that can be followed, because the enamel thickness in cervical part is the minimum. Second point to note is the fact that the enamel thickness is slightly thicker in the middle part of your cross section of the tooth, where there is increased light scattering. So you want to match your enamel shade against the middle part of your restoration. And then, based on the age of the patient, the incisal aspect of your tooth may or may not have opalescence effect. So the incisal shade is what you match against the inside, based on how much incisal effect that you see. Is there an increased opalescence? Is there increased attrition that has happened, which is why the length is shorter? In that case, you wouldn't need an incisal shade. You may just continue with an enamel shade in those cases. So it really depends on the age of the patient. If you're looking at an increased incisal effect, you will probably use incisal shade, because you want to mimic the original tooth structure. However, if it is an older patient where there isn't much incisal effect that you see, not much opalescence, you may be able to create the same effect with just two shades, that is dentine and enamel.
Thank you, Doc. And now we have Dr. Mehta. Please, Dr. Mehta, if you want to ask directly.
Okay. Thank you, Dr. Ime. I want to ask about self-etch adhesive system, Doc. You explained about pH in adhesive system, especially in self-adhesive system. What I know, there is a classification for pH in adhesive system. There is strong, mild, and ultra mild. According to Mr. Sodi, what is better? Is strong, mild, or ultra mild? And second question, Doc. What is better according to Miss Sodi about adhesion or bond strength? It's better self-etch adhesive system or universal adhesive system? Thank you.
Yeah. So when it comes to your self-etch or universal bonding system, it really depends on the technique that you're using. When it comes to the technique and the science that we are using, which is combination of ternary solvent system as well as a bipolar molecule, we are able to achieve higher enamel bond strengths as well as higher dentine bond strengths. So if you look at techniques, total edge bonding agents in general are associated with higher enamel bond strengths. Self-etch bonding agents in general are associated with stronger or lower post-op sensitivity, but the enamel bond strength is going to be weaker, because the highest enamel bond strength that is achieved is using phosphoric acid, as we discussed in the presentation. And so depending on your indication or depending on the case, if you need to achieve a high bond strength from your enamel, you would follow a total etch technique on enamel, right? And if you think that your restoration has very minimal enamel, it is a deep cavity, there is a risk of post-op sensitivity, there is dentine that is involved, and you need high bond strength from dentine, a self-etch technique is preferred in those cases. Now, the advantage of universal bond or OptiBond universal is that it gives you the best of both the worlds. So you, because of the ternary solvent system as well as the GPDM monomer, you're able to achieve high bond strength on enamel as well as high bond strength on dentine while minimizing the chances of post-op sensitivity. The bond strength comes from the fact of what kind of technique are you going to use on the tooth surface. So that is determined by your clinical indication. So if your clinical case has higher enamel involvement, you want to use a total etch or a selective etch technique in that case. If it is going to come from a deep cavity where there is dentine involvement, you want to select a selective etch or a self etch technique using your universal bond. So it has to be a combination of your bonding agent as well as the technique that you follow to do the bond.
Okay, Doc. You explained about technique in dentine and enamel. Maybe one question, Doc. How about dentine? In dentine, we talk about bone strength or adhesion. Is monomer functional? Is give effect to bone strength or no, Doc? Or not, Doc? In dentine, Doc. Monomer functional. As I know, if we talk about GPDM, we talk about monomer functional, acidic monomer functional. Is there is a type of monomer functional give effect for bone strength or not?
The functional monomer of our GPDM, the type of, if you're talking about, I think what you're referring to is how the monomer helps in the bond strength. Now, because of the form, because of the structure, so if you remember, our GPDM is a bipolar molecule. So it is a smaller molecule. So it has two methacrylate groups, and then there is a phosphate group, which makes it a small molecule. It's not a very long molecule. If the molecule is small, it helps in better penetration of the molecule, which contributes to the bond strength as well. So yes, the monomer also helps in the bond strength because of the size, it is able to travel and it is able to penetrate better. So that helps in the bond strength and resin tag formation as well.
Okay, thank you, Dr. Sodi. Enough for me. Thank you very much.
Thank you, Dr. Meta. Dr. Sodi, we come to the other question from a Q&A box from Prof. Ardo Sabir. He asks about which condition of cavity we can use selective etching or total etching. Thank you.
Yeah, so this one I think just covered a part of it. So based on your indication, if it is a cavity that has maybe more enamel involvement, you want to make sure that your bond strength, maximum bond strength comes from enamel. You would want to consider a total etch technique or a self etch technique, a selective etch technique, where you're selectively etching the enamel. If it is a deep cavity where enamel is minimal, maybe only on the cavo surface margins, and there is a lot of dentine involvement, in those cases you would probably gravitate towards selective etching or self-etching techniques, because using total etch on a deep cavity can cause post-op sensitivity.
So it's about the hypersensitivity.
Yeah.
Hypersensitivity. Okay, thank you, Doc. And we have one more participant, Dr. Inna Mutmainna, silahkan. I'm sorry, Dr. Inna, please. Dr. Inna, are you monitor? Yes, please, Doc.
Okay. Maybe I want to continue the question from Dr. Meta about functional monomer. Beside GDPM, we know there's 10 MDP, 9. We know that GDPM has long resin tag effect. So if does GDPM also have an interaction effect with hydroxyapatite, so that can provide good durability or not?
Yes, so it does have an interaction with the monomer, with the enamel surface as well. So as I explained, it has a bipolar molecule. So it has phosphate group and it has dimethacrylate groups. So the phosphate group is the part that interacts with the enamel surface and causes and helps in formation of an ionic bond, which helps in the chemical bond strength of the of the restoration. So because of the fact that the phosphate group is able to bond with the ions on the enamel surface, it contributes to a chemical bond. The same phosphate group helps to also etch the tooth surface, which creates a roughened surface of enamel, which helps in micromechanical bonding. So there are two mechanisms of bonding. There is a micromechanical bonding that it helps, and then there is an ionic bonding that it helps in order to increase the strength of the bond to the enamel.
Okay, thank you, Doc.
Okay, I think it's enough, Doc. Thank you very much, Dr. Sodi, and farewell, ladies and gentlemen. Finally, we come to the end of the presentation, and we would like to say thanks again for the presenter, Dr. Aziz Sodi, for your informative and interesting talk to the audience and for your active participant in the seminar, and that the seminar held by Hasanuddin University, Faculty of Dentistry, Hasanuddin University, collaboration with PT Gratia Jaya Mulia and Dental Medicine Faculty of Airlangga University. And hopefully the presentation will be beneficial for everybody. Thank you, Dr. Aziz Sodi.
Thank you so much for the questions. I think very interactive and very good questions that were asked. And yeah, I hope this has given you some insights into the latest products. So thank you, everyone.
Thank you for your attention. Good noon. Wassalamualaikum warahmatullahi wabarakatuh. And
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much. Thank you, Dr. Nur Hikmah, and also the speaker, Dr. Aziz Sodi. This session is very, very clear and inspiring our knowledge. Now, next we will attend the virtual certificate submission to our speaker, Dr. Aziz Sodi, followed by closing speech delivered by Dean of Dentistry Faculty, Hasanuddin University, to Dr. Muhammad Ruslin, MKes, PhD Specialist Bedah Mulut Konsultan. Please, Doc, the time is yours.
Terima kasih, Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Good day, everybody. The Honorable, the Vice Rector, Research and Innovation, the Honorable, our special lecturer, special speakers, Dr. Aziz Sodi, and ladies and gentlemen, and all distinguished participants, Alhamdulillah Rabbil Alamin, all praise and gratitude to Allah Subhanahu wa Ta'ala, so that we all have the time and opportunity to participate in this event. Virtual International Symposium Series 10 with the theme Innovation in Aesthetic Composite Systems, a restorative update, that organized by two institutions, Faculty of Dentistry, Hasanuddin University, also with PT Gratia Jaya Mulia. I am very happy and delightful with all participants and of all fellows. Ladies and gentlemen, it's an honor for us to able to meet and have a shared knowledge in this occasion. As a clinician in pandemic situation, we need to be creative and, of course, constantly update our knowledge and be open-minded about restorative innovation and its application into our profession. A heart gratitude and respect to distinguished speakers, Dr. Aziz Sodi, the product manager at CAFO Care, for providing the opportunity to share valuable knowledge and experience with us. I hope the trend of COVID-19 will decrease soon and we can invite you to another symposium meetings in Indonesia especially in Makassar. To all participants, I observe your excellent presentation and active discussion, so I can conclude that our symposium got a positive impact and purpose of our event has been accomplished. I really hope to see you again at our next international and national events. Once again, I thank all of you for joining this symposium and look forward to seeing you again. May we all be given health and maintain health protocols so that we can fight with COVID-19. Finally, on behalf of Faculty of Dentistry Hasanuddin University, I would like to express my appreciation to all participants for taking part to this symposium and wishing the next prosperity of our future event. Thank you very much for your attention and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
And for our special speakers, Dr. Aziz Sodi, this is your certificate. And again, thank you very much. And we hope you can come in our university, Faculty of Dentistry, Hasanuddin University in Makassar, Indonesia. Thank you very much.
Thank you so much, Doctor, for this recognition as well as this platform where we had interactions with the students. Thank you very much for this. It was great.
Yeah.
Okay, thank you very much, Dr. Ruslin. Now, ladies and gentlemen, distinguished participants, we come to the end of the webinar. And for your information, this virtual international symposium series will be continued next month with another topic, oral leukopplakia, recent knowledge and understanding. Hopefully, we will see you again next time. Thank you all for your kind attention. Wassalamualaikum warahmatullahi wabarakatuh and good afternoon.
Waalaikumsalam warahmatullahi
wabarakatuh.
Thank you.
Thank you very much.
Thank you.
Bye.
Thank you, Dr. Sodi.
Thank you, Dr. Sodi.
Hope we can
Bye.
meet you soon.
Yes, bye-bye.
Dr.
Thank you.
Afif.